Good afternoon and welcome. I request the dignitaries to occupy there. Actually, you'll see that Vidya doing all these things in the OT all the time, pushing, pulling, adjusting, just to make sure everything is all right. Vidya, for once, this is not the operation theater. Please sit down. Huh? Endoscopy அப்படிதான். So everybody is scared of surgery, including myself. Actually, they are not scared of the surgeon, they're scared of the anesthesia. They're scared of becoming unconscious and they are not very sure whether they'll come back to consciousness. And this very important area is covered by anesthesiologists. These days, most of the patients don't know their surgeons' names. Definitely, they do not know the anesthesiologist's name as to who the anesthetist is. Quite often, the anesthesiologist who sees them in the pre-op is not the one who sees them in the theater, and it is one of the reasons why patients don't remember the anesthesiologist's name. And um, they're the unsung heroes and heroines, actually. Uh, I've seen some real wonderful anesthesiologists who not only see the patient pre-op, but they take very, very good care intra-op, and they also see patients post-op. Actually, the anesthesiologists who see patients post-op are the ones who are remembered. The ones who don't see are generally not remembered. And then, the thing of uh, sacrifice, the thing of philanthropy, I think is synonymous with anesthesia because actually, frankly, many of you do not know how anesthesiologists look like because they're never outside, they're always inside. And when you see them in civil dress, you can't make out who they are because if at all you have seen them, you've seen them only in operation theaters. Now, all these years, I worked in corporate hospitals where anesthesiologists are paid one-fourth of a surgeon. If a surgeon fee is that much, one-fourth is the. So surgeon does more cases, the anesthesiologists get more money. And that is the reason why the anesthesiologists are always willing to operate at any time. But this is the first place I've seen where anesthetists get a fixed salary, but they're there at 7 a.m., they're there at 7 p.m. I wonder how, because they don't get any extra money by starting early or not get extra money by starting late. I think that is a culture that is developed, and I think Dr. Vidya is so much responsible for that culture. I think they'll all give a big hand to her. Having said that, me and Dr. Vidya are classmates. I don't remember when I did any emergency surgery. In the last 10 years, I have a batch of MCH assistants in my hospital who do all the emergency surgery. Last 10 years, I never done any. Of course, now they don't call me also. I don't think there are any emergency surgeries here. Vidya is there every third day or fourth day for emergency. I don't know at what age will she stop doing that. And if I ask her, just why don't you come for dinner or what do you mean? I am not. Ah. Nah, see the no, whenever no, I'm on call, I can't come. I said I'm also on call, but nobody calls me. I made my life like that. You know, they say I know an anesthetist who says if you want to become a surgeon, become a lion, and if you want to ride a lion and control the lion, become an anesthetist. And here we have Vidya who controls all the lions in the right way. And today, we'll see the Lions family.
Over to you, Najiha. Good afternoon, everyone. Starting with another magical moments in medicine. What's this? What do you remember? Okay. Seeing umbilical cord, what do you remember? Okay. Some other things? Okay. 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 And today's topic is going to be unlocking the stem cell secrets of umbilical cords. So, as you said, umbilical cord is the lifeline between the mother and the child during pregnancy. It connects the fetus to the placenta and it becomes the delivery medium between the child and the mother. It has two arteries and one vein and a Wharton jelly is also there. The one which is very light blue is your jelly one. So, what's the important of it is the stem cell in umbilical cord. So the umbilical cord has some caudal blood and some it has cord and tissue. That is what we saw is that blue one jelly thing, and there is also placenta. This is the the things that the cord will have: the cord blood, tissue, and the placenta. So this cord plate will have the hematopoietic stem cells, and the cord tissue will have the mesenchymal stem cells, and the placenta will have both. So when you collect the cord blood, and it will form the blood and immune cells, so RBCs, WBCs, platelets, and that will be useful to treat leukemia or lymphoma, all blood related things. It will be useful to treat. And when you collect a cord tissue and you store it, it is mesenchymal stem cells, so it can form bone, cartilage, nerve, and tissues. This is the difference between the blood tissue. And you collect placenta, you get both the hematopoietic and mesenchymal stem cells, and it can be used to treat everything. The potential is used to treat everything. So the first umbilical cord blood transplant happened in France and Paris. Was around the 1980s. The only source of stem cell was till that was the bone marrow transplant. So people wanted a easier way, and then they found out that the umbilical cord has a, which is considered as a medical waste, was rich in stem cells. So first cord blood transplant was 1988 for a very little boy. He is that Matthew Farrow, who was very young when he underwent it, and his recent picture of that Matthew Farrow's that one. So he was suffering from Fanconi anemia, which is when there is a DNA genetical problem and all your cells doesn't produce or multiple cells, so they will have anemia, leukemia, all those things will be there. All the cells will be very low. So for that, umbilical cord transplant was done for him. That cord was here, but it was not his own. So as he was suffering from Fanconi anemia, and his there was a newborn sister of him. So her cord bless was transferred to him to treat the Fanconi anemia, and he got cured also. It was done by Dr. Ilyana Gluckman. So what will be the advantage of the umbilical cord stem cells? Or they are collected painlessly and ethically at birth. They are easier to store and preserve, and they have a lower risk of disease transmission compared to the adult source also. The limitation is that the cord blood volume may be sometimes low. Thank you. And one thing is they have public and private banking. So if you give it to a public banking, it can be useful to anyone. And if you have a private banking, then it will be used, they will be storing it for you and your siblings. So it will be up to 25 years of the age. The stem cells remain the same, and it can renew itself, and it can grow like whatever cells it want. Thank you.
Thank you, Najiha. Now, I would like to call Dr. Vidya, ma'am.
So thank you everyone for assembling despite long weekend and a lot of people on leave, but still you all came. So Dr. Radhakrishna was going, praising so much. So இது புலி ஒரு அடி பாஞ்சா குட்டி வந்து 16 அடி பாய்பாங்க. So my குட்டீஸ் are now going to take over.
When life trembles between one heartbeat and the next, a calm voice says, "I've got the airway." In the storm of an emergency, when panic fills the room, the anesthesiologist becomes the still point, restoring breath, rhythm, and hope. From the operating theater to the ICU, from a newborn's first gasp to a fading pulse revived, they guard life in its most fragile moments. No spotlight, no applause, just quiet strength, steady hands, and a promise kept to never let go when life hangs in balance. On this World Anesthesia Day, we salute those who give life its second chance, anesthesiologists, the silent guardians in every healthcare emergency.
Good afternoon to all. And since it's a pre-prandial session, we'll make you enjoying also. So we have two topics. So one, I'll be starting with evolution of anesthesia. Anesthesia, which we talk, it is incomplete without talking about the history. Now this topic is evolution. So let me give a brief idea on how it started and how it's going. And yeah, that's it. So we'll get started. Yes. So I'm Chendal Raja, senior consultant here from there. Yes, please. So that's it. So anesthesia has evolved from crude pain relief methods, like it was surgery before anesthesia days, where pain was a thing which was not so controllable. So after anesthesia started, so surgery transformed surgery into a ordeal which was safe and had a controlled experience. So it's from ether inhalation. It started in the 1840s. To be more specific, it is 1846 to the AI-driven precision which we see today or we work today, and the journey is revolutionary. So each era has been breakthroughs in the patient safety, in the comfort, in the surgical outcomes. So before anesthesia, as I said before, surgery meant an excruciating pain and fear. Now anesthetist and anesthesia make sure that patients sleep safely through the life-saving procedure. So this presentation would be that anesthesia has progressed from ether drops to the closed loop, the robotic system. And this evolution reflects the advancement in pharmacology, technology, and perioperative care. So the history is incomplete without talking about this slide, without talking about this day. That is, we celebrate it as World Anesthesia Day, which is October 16, 1846, at Massachusetts Hospital, where first time the world realized and the scientific fraternity believed that surgery could be painless. So this was the dental extraction which was performed in front of all the elite community there by Sir W.T.G. Morton. So he demonstrated ether to be used for anesthesia for performing the procedure. And the scientific world understood that surgery can be painless. So this marks an iconic day or a date. And this incidentally happened to be my chief's birthday. So that is on a lighter note. So what it had, the impact is, so the anesthesia was born. It was the starting point for a modern surgical anesthesia. People believed that surgery was pain-free, it was safer. So that's it. So why ether at that time? Primitive, but ether was the one which was available, which was easy to use, effective to administer. It was then safer for the older methods, but it was slightly, since it was so primitive, it was in 1846, so it was slightly flammable and there were some airway irritation things. And so that paved way for the anesthesia which we see today. So October 16. So the second one. So as we grow, anesthesia also grew. So what? It was a chloroform era. And this was initiated by Sir James Young Simpson in 1847. So the next. So what had, so you used chloroform, and especially in obstetrics. So it had a very good role in obstetrics, all this labor anesthesia, which we see today, was initiated by him by giving chloroform, and it was widely adapted by then there. And so it was easier to use. It was reasonably more tolerable than ether, and it was widely accepted. And one thing was Queen Victoria. We was famously used chloroform during the birth of Prince Leopold. So that boosted the public acceptance, and anesthesia became more safer and popular at that time. So as I said, the advantages of this was a faster onset of anesthesia, less irritating compared to ether, and was easy to administer among doctors. That's what it is. So disadvantage. So we say advantages, we say disadvantages. That is science. So disadvantages had a narrow safety margin. I mean, mild slight increase in cardiac death was noticed, then it was toxic to liver and heart. And this period was slowly replacing the other anesthetic drugs. But still, as far as history is concerned, this is an iconic achievement. So next slide. So coming to the start of the recent anesthesia one, so local anesthetists, which is the one which we use in our day-to-day practice. And I'm sure all the surgical dignitaries, all the paramedical dignitaries also tend to know. So this was in the late 19th century. So what? In 1884, Carl Koller used cocaine for the eye surgery. And this was an achievement which paved way for the local anesthetic to be there. So procaine was there, which was introduced in 1905. Then came the other drugs like the advancement lidocaine and other safety drugs, which we followed by bupivacaine, whatever. We use it till date. So advantages. So previously, making unconscious or knocking the consciousness was one of the options. So this discovery made sure the patient stays awake. So this was another iconic achievement towards the advanced anesthesia because it numbs only the target area. The patient need not be totally knocked off. And so there was a quick recovery with few side effects, but that was okay. It was a quick recovery. So as I said, disadvantage is one, it was a short duration in case of major procedure. So that time the toxicity risk was there, and sometimes it may not, the pain was not fully covered. So those issues were there, but still it forms as an iconic discovery in making the patient stay awake and making anesthesia safer and more versatile, and the surgery also being safer. Next slide. So Boyle's apparatus, we have come a long way from this machine, which is kept in museum or certain medical colleges nowadays, to all those advanced workstation. So it was introduced by Henry Edmund Boyle in UK in 1917. So this was another step in the advancement of anesthesia, where you had a more controlled environment with the from the ethers, from the chloroform. You had a mixture of gases and anesthetist vapor, where you can administer anesthesia to a patient safely. Just to have a brief of what this boils was. So we had a cylinders, mostly it is oxygen and nitrous oxide. We had a flow meters where you can have a controlled gas flow of all these gases. Vaporizers to further deepen the plane of anesthesia. And we had breathing circuits where we had a better access for controlled ventilation of the patient. Then all the pressure gauges and safety valve to ensure the anesthesia was safer. So that what I was saying. So the thing is, the significance of this is there was a shift from simple inhalers to the precision anesthesia, which we see today. Okay, so this mission was the Pulayar Suli for all the workstation which we see today, right? So the next one. So we always talk about advances. So this is one advances in inhalation agents. So as we were talking about ether, chloroform, and now came these inhalation agents, these halothines, which was initially smoother induction and less irritant, and followed by isofluranes, which was more stable, and sevoflurane and the desflurane, which we use it today with all the advancements. And these were the image shows the various vaporizer which we use those inhalation agents. So these advancements and advantages is that they have a better control over the anesthesia during a surgery for a patient, ensuring a faster recovery, and this way an improved safety for the patient. So the precise, safe anesthesia delivery in modern surgery, these are the elements. Next slide. So intravenous anesthesia. So let me go back to history. So the early developments I'm sure all the peers or my surgical dignitaries would know. 1930, it was thiopentone for a rapid induction. This was one breakthrough achievement in induction agents. So, followed by which there was use of ketamines and benzodiazepines, and then came the drug which everybody is fond of, an anesthesia fraternity, propofol. So propofol became a golden standard because of various factors. It's smooth induction, it's rapid induction, there's early onset and early recovery from it. Now it became a golden standard, and it is used for daycare surgery, short procedure, minimally invasive, so it is less airway irritant also. So disadvantages, it needs a since its mechanism of action and onset time is short, it needs a continuous infusion for a longer surgery and certain specific side effects. Otherwise, it is one induction agent which is widely appreciated and used. That is what it revolutionized. So no, we come to airway management. So earlier days, as I said, there were no airway devices specifically, and so since the advancement of anesthesia, so comes the airway devices. Initially, it was only manual methods. So now we have come to the airway devices. So 1800s, it was mild inhalational. The 1900s, then came the oral airway. So these are the various sizes of oral airway, right from pediatric to adult, with standard measurement which fit each and every patient. Because pre-oxygenation and during general anesthesia before intubation, this assumes significance. And the World War II, I just wanted to highlight, otherwise even before World War II, intubation is standard. It is just a term, that's it. So intubation became more safer and more precise. And then comes the modern era of equipments, the advancement. LMA, the laryngeal mask airway, and the fiber optic and video laryngoscope all had improved the safety of the patient, precision in anesthesia, and safer surgeries. So coming to monitors. Earlier days, it was pulse and respiratory rate to start with, which was the basic monitors. Then 1800s, it was just blood pressures, not time mildly the temperature monitoring. Then in 1900, then came the ECGs, where we had a good idea on the cardiac activity. Then the oxygen measurement was introduced. Later on, we had capnographies, where we would have a better assessment of the respiration and automated BP also. Now it is the modern era, which we see the multipara monitors, where you can have a precise idea of how the heart rate, saturation, end-tidal BP, and invasive BP throughout. So coming to muscle relaxants, adding a note. So earlier days, it was only deep anesthesia with ether and chloroform. Then in 1942, Courier was introduced. So it became a history now. So hardly that is there. So 1950s, the synthetic relaxants were developed. And for the first and the foremost thing we even follow till date is going to be succinyl choline, which is a depolarizing muscle relaxant, uh, which has a definitive role during surgery in anesthesia. And then the advancement, we progress for non-depolarizing agents like vecuronium, atracurium, rocuronium, which improves the control of anesthesia during surgery. So the modern era is safer drugs, and we have even advanced to some reversal agents like succomadex, which ensured a rapid recovery. So we have talked about general anesthesia. So coming to other side is regional anesthesia. So we had all primitive methods of regional anesthesia in the previous years. So after I said 1884, cocaine was introduced. That was a breakthrough in anesthesia. So they were in earlier 1900s, spinal needles and epidural techniques were followed, where you can just one part of the numb one part of the area which is subjective to surgery. And 1900s, there were advancements in the local anesthetic. Till date, it's been evolving. And to add a note on it, now it's the modern era, the latest generation is ultrasound guided blocks, which we normally use, which we see visually. We have a precise accuracy, and then we administer anesthesia. So safety standard, adding a note on it. So initial days, the safety standard and monitoring was not need to get evolved. In 1900s, the basic guidelines were followed. In the 80s, standard monitoring was there, like ECG, BP, and saturation. 1990s, WHO and ASA had a set anesthesia safety protocol, and now the modern era has all those safety checklists which we follow in non-hospital safety checklists and patient details. All your monitors have an advanced alarm where something goes wrong. We easily pick up things. You have the simulation training where you can educate the graduates or the counterparts for ensuring high standards and safety for the patient during anesthesia. So that's one. So this is the one, artificial intelligence. Now everyone talks of it, no? Whatever be the topic, artificial intelligence. So it's robotics in surgery and anesthesia. So we have the advanced robotics like Da Vinci 1, where you have, it's basically a closed loop system where things are programmed, like patient set parameters, patient weight, height, its illness, its dose is being programmed so that which can address to the drug delivery system. And this is basically a robotic machine which aids. I know that Patasar would have been knowing this. So these are the arms. This is a Da Vinci 1 where you can have where you can set certain parameters so that the precision, accuracy, and surgical site vision can be improved. So supporting the faster decision making, and it reduces the at times surgical error also. So that is that. May ensuring smart anesthesia as well as greater accuracy in the surgery. So that's it. So AI helps in personalizing anesthesia by predicting patient responses also. Yes. So future of anesthesia. We have talked about history. We have talked about the evolution. We'll put a note on future of anesthesia. It focuses on precision, personalization, and automation. So that is what we have been talking. So AI, robotics, and all these predictive analysis is just going to make anesthesia safer, more patient specific, and surgery safer. So next generation anesthesia will combine this automation with human expertise for optimal and better outcome. So what does future have in store? Future trends include smart monitoring, gene-based drug response, and automated anesthesia delivery. Okay, so what is the take-home message? Conclusion. So from ether to AA, the goal remains the same for anesthesia. It is safe, painless, efficient care. So keeping patients safe is our mission, which we do it. So the journey of anesthesia continues with innovation and care. Together we shape the future of anesthesia, safe anesthesia. Thank you all for such a patient listening. Thank you. So it will be followed by the other section. Yes.
So our motto always is safe anesthesia, safe surgery, safe patient. So if anesthesia and surgery are safe, patient is also safe. So this year, World Anesthesia Day, the theme is anesthesiologist in health emergency. So my team has put together a scenario where everybody is running helter skelter, and in the end everything goes right. So we'll give them a few minutes to get set up. And before that, if any of you have any questions, you're welcome to ask.
Good afternoon, everyone. So wonderful to meet you all here. We, the anesthesia team, multidisciplinary team, come forward, racing against time today, multidisciplinary response. We are going to manage a massive hemorrhage today. In trauma, time is life and time is essence. And the resuscitation team stands united. Each member is clear with their role. Communication is precise and the actions are swift. Introducing the team members of role play, Dr. Saumya, the anesthetist who's posted in the ER, Dr. Mohan Rao, surgeon, Dr. Sendil and I, the anesthetist, Vignesh, OT technician, Priyanka, Vignesh, OT technician, Munusami brother, who's the patient, circulatory nurse, Priyanka and Kamesh, Rajita, scrub nurse, Dr. Akansha, ICU doctor, Twinkle sister as the attender as well as ICU staff. A trauma call announced patient is brought in after an RTA. 35-year-old Mr. Kumar sustained a high velocity trauma. As the sound of approaching ambulance echoes down the corridor, the resuscitation team stands ready. In trauma care, time is life and teamwork is survival. Sit back and enjoy our wonderful, enthusiastic team resuscitate, stabilize, and save the day for the patient from this life-threatening emergency. Over to Dr. Soumya.
சார் நான் வந்து இஆர் டாக்டரு. உங்கள் பேர் என்ன? ஓகே. வயசு? ஓகே. என்னாச்சு சார் உங்களுக்கு?
சிக்னலில் வண்டியில் வரும்போது ஆக்சிடென்ட் ஆயிடுச்சு.
எப்போ?
காலையில்.
ஓகே. மானிட்டர்ஸ் கனெக்ட் பண்ணுங்க ஆதி.
ஓகே மேம்.
சார் இந்த கை கால் தூக்குங்க ஒரு டைம். கை தூக்குங்க. அந்த கை நல்லா வாய்ந்துருங்க சார். ஓகே. White sir.
Ma'am, BP is low, ma'am. 80/30, ma'am. And then pulse rate is 130, ma'am.
2 large bore IV lines secure பண்ணுங்க.
Okay,
Either 18 or 60. Rush 1 liter of RL. Send blood for sampling.
Okay, ma'am.
வலி அது நிக்கு சார். இங்க
Ma'am, IV lens secured, ma'am. And blood is collected, ma'am. And sent to for sampling and blood group, ma'am. RP2 blood.
RL கனெக்ட் பண்ணுங்க.
Okay, ma'am.
இப்போ பிபி எவ்வளவு இருக்கு?
Ma'am, rest 1 liter RL, ma'am. BP is still same, ma'am. 80/30.
Looks like some blunt abdominal injury. Let's get an ultrasound machine and put a scan.
Okay, I'm going with ultrasound.
சார் கூட அட்டெண்டர் யாருன்னு இருக்காங்க? சார் யாரு?
Ma'am, use ready, ma'am.
ஓகே. There's a collection in the abdomen. Looks like it needs to go for laparotomy. Let's inform the surgeon and on-call anesthetist.
Okay.
In the meantime, arrange for O negative PRBs, 4 units. Inform the blood bank.
Okay, ma'am. I inform to blood bank first, ma'am. Hello? Hello, blood bank. பிரதர் இயர்லேருந்து ஆயத்தை பேசுகிறேன். இங்கே ஒரு லேப் கேஸ் இருக்கு ஒன்று, ஓகேங்களா? ட்ராமா பேஷண்ட். ஸோ ட்ராமா பேஷண்ட் ரிசீவ் பண்ணியிருக்கோம். எங்களுக்கு வந்து ஓ நெகட்டிவ் வந்து பிளட் தேவைப்படுது, பிஆர்பிசி 4 யூனிட் ரிசர்வ் பண்ணிடுங்க. நான் வந்து பேஷண்டோட கிராஸ் மேட்சிங் அனுப்பிச்சிருக்கேன். அதை சீக்கிரமாக வந்து ப்ராசஸ் பண்ணுங்கள். பேஷண்ட் ஓடி ரிசீவ் பண்ண போகிறோம். கன்சர்ன் எல்லாமே உங்களுக்கு வந்து நான் அனுப்பி விட்றேன். நீங்கள் பிளட் ஆஸ் சூன் அஸ் பாசிபிள் சீக்கிரம் அனுப்பிச்சி விட்ருங்க.
ஓகே ஃபைன். எமர்ஜென்சி அன்கிராஸ் ஓ நெகட்டிவ் பிளட் நான் இப்போ உங்களுக்கு சென்ட் பண்ணுறேன்.
ஓகே பிரதர், தேங்க்யூ. எஸ் மேம், பிளட் I'll inform. I informed the surgeon honestly, they are on the way, ma'am. As soon as I informed to OT, ma'am, OT service side.
Good morning.
Hypotension, tachycardia. We have secured the IV lines and rushed 1 liter of saline and one PRBC is going on, sir. O negative. Fast, there's a collection in the abdomen.
Who did the fast? Yeah, okay. How much is the collection there?
It looks like around something like 300 to 400.
How is this vitals?
Hypotension, tachycardia.
Okay.
Looks like a shock.
என்னங்க ஹலோ ஹலோ
Sir?
உங்கள் பேர் சொல்லுங்க என்னாச்சுங்க
சைக்கிளில் வந்தேன் அப்படியே சிக்னல் சிக்னல்
எத்தனை மணிக்கு ஆச்சு இது ஞாபகம் இருக்கா?
அது 7 மணி இருக்கும்.
ஓகே. கூட யாரும் இருக்காங்களா?
நான் மட்டும்தான் வந்தேன். ஃபோன் பண்ணால் ஹோட்டலேருந்து வந்துடுவாங்க.
சரி, உங்களுக்கு ஸ்கேன் ரிப்போர்ட்டெல்லாம் பார்த்துருக்கேன். கொஞ்சம் அடிபட்டுருக்கு, பிளட் கலெக்ஷன் ஆகிருக்கு, உடனே ஆப்ரேஷன் பண்ணணும். அவங்க வர வரைக்கும் நம்ம வெயிட் பண்ண முடியாது.
சரி,
நீங்கள் ஓகே சொன்னீங்கன்னா கன்சர்ன் கொடுத்தீங்கன்னா பண்ணிவிடுவோம். உங்கள் வீட்டுக்காரனுக்கு ஃபோன் பண்ணி சொல்லிவிடுவோம்.
ஓகே சார், பண்ணிடலாமா? பண்ணிவிடுங்க சார்.
ஓகே, ரைட்.
பிபி ஏதாவது இருக்கா சார்? ஆஸ்மா, டிபி, தைராய்டு ஏதாவது? அலர்ஜி ஏதாவது இருக்கா?
ஒன்றும் இல்லை.
சாப்பிட்டீங்க?
எத்தனை மணிக்கு சாப்பிட்டீங்க?
ஓகே.
இன்னைக்கு ஒன்றும் சாப்பிடல இல்லைங்களா? ஸோ உடனே பண்ணிடலாம்.
பயப்பட வேண்டாம். ஓகே, பார்த்துக்குறோம். உங்களை எமர்ஜென்சியாக எடுக்கணும் இமீடியட்டாக நாங்கள் இன்ஃபார்ம் பண்ணிடுறோம். அந்த நம்பர் மட்டும் தாங்க, உங்கள் அட்டெண்டர் நம்பர் நாங்கள் இன்ஃபார்ம் பண்ணிடுறோம்.
Please inform the medical superintendent that we're taking up surgery without the consent of the relatives. Let's proceed. Yeah, other formalities to be processed. And get the surgery pack too. Don't wait for the results. Just get the cross matching done and talk to the blood bank and see that it is done in another 5 minutes and not at their own pace. We need it fast. Okay. Shift the patient. Another 5 minutes. Patient should be in the OT. And have you informed the OT nurse?
We have informed, sir.
Okay. Well, let's move to the theatre. Shift the patient.
HP is 5, mild acidotic.
Ma'am, blood is, where is your blood, ma'am? Shall I transfuse, ma'am? O negative.
Starting O negative blood. Coordinate with the OT.
OT, okay,
Let's
ma'am.
shift in. Emergency, let's shift and start.
Okay, ma'am. ஹலோ சிஸ்டர், ஏர்லேருந்து.
எம்எஸ்ஓடி பிரதர் சொல்லுங்கள்.
சிஸ்டர், இங்கே ஒரு பேஷண்ட் இருக்காங்க, ட்ராமா பேஷண்ட் இருக்காங்க. ஓகேங்களா? ஸோ மவுண்ட் ரோஸாவை பார்த்துட்டாங்க, அந்த சந்தனா பார்த்துட்டாங்க. இப்போ ஓடி கிடைக்கிற மாதிரி பிளான் இருக்குது. ஷெடியூல் ஃபார் எமர்ஜென்சி லேபரேட்டமி. ஸோ அதை இன்ஃபார்ம் பண்ணுறோம். ஓகேங்களா? கன்சல்ட் கிளினிக்ஸ் ரெண்டுமே வாங்கிட்டோம் சிஸ்டர். பிளட் ட்ரான்ஸ்ஃபர் ஒரு ரெண்டு பேர் ஆன் ஃப்ளோரில் இருக்குது. பிளட் குரூப்பிங், கிராஸ் மேட்சிங் ரிப்போர்ட்ஸ் எல்லாமே நான் ஃபாலோ பண்ணி கால் பண்ணி தரேன். இப்போ உடனே பேஸ்ட் நான் செக் பண்ணுறேன்.
ஓகே பிரதர், வில் ப்ரிப்பேர் பை.
ஓகே சார், தேங்க்யூ.
ER and patient is en route to the OT. OT team members, technician, scrub nurse, circulatory nurse.
Yes ma'am, theater is ready.
Massive hemorrhage coming up in the ER. Let's be prepared.
Yes ma'am.
Rajita, scrub nurse, circulatory nurse, come. Is the laparotomy set ready? Rajita, is it ready? Suction, vascular clamps, everything ready? Vicky on our side, emergency medicines, defib, all the machine check, everything has been done?
All machines are checked ma'am. Emergency drugs are loaded.
Airway trolley, massive transfusion, we need rapid infusers.
Sure ma'am, everything is done ready.
Okay, let's be fast. Circulatory nurse, coordinate with the blood bank.
Okay, ma'am.
Okay, about the blood, massive transfusion protocol.
Okay,
We'll probably be needing it. Okay?
Okay, ma'am. I call blood bank.
Sister,
எம்எஸ்ஓடியிலிருந்து ஒரு எம்டிபி ஸ்டார்ட் பண்ண போகிறோம். ப்ரோட்டோகால் ஸ்டார்ட் பண்ணிக்கோங்க.
Okay, sister. 4 unit PRBC, 4 unit FFP, 4 unit plasma. Activated, sister. Sending.
ஓகே பிரதர்.
We call a senior anesthetist as well. We need an extra hand.
sisters, I need two nurses to assist me.
Let's do an ID check.
Please get 2 nurses.
Holding bay.
ஓகே மேம்.
ID check.
சார் உங்கள் நேம் சார்?
It's an emergency. பேர் சொல்லுங்க ஐயா.
குமார்.
Okay.
ஓகே சார்.
Sister, are you ready?
You are ready,
Yeah.
sir.
Please come. Let's get. Don't waste time.
9,000, 1, 2, 3, 4. Okay, checked.
Okay, ma'am.
Let's wheel in the patient.
So we're wheeling in the patient. Safety pass completed. Standard procedure follow. So we'll get started.
Okay, let's connect the monitors. Blood pressure, pulse ox, come on. ECG leads. White ball lines already on floor. Central line, waist pipette ready. Heart line as well.
Good afternoon, ma'am. Good afternoon, sir. Anesthetist review. Is patient identification reconfirmed? Any anesthesia equipment issues or concern? Anesthesia safety check has been completed. Risk of any blood loss? Two IVS bar central access and fluid planned blood products arranged, sir. Thank you, sir. Thank you, ma'am.
Good morning, sir. Time out, sir. Patient name, sir.
Sister, I think anesthetists have taken care of everything. Let's not proceed with that. Let's carry on. Please start the surgery.
Sir, procedure plan, sir.
Procedure plan is already discussed. There is emergency laparotomy, probably splenectomy. I think we should not waste time. Please come. Sister, please come. Let's start. Anesthetist, are you ready?
Sir, injection magnus put given, sir.
Thank you very much.
Sterility
Yes.
confirmed, sir.
Thank you very much.
Give me the scope. Is the tranexamic acid going? 1 gram. Come on.
Get it done. An antibiotic also can give it. Okay.
Antibiotic is in.
Yeah.
Magnex.
Antibiotic.
Okay, we are tubing the patient, going in, give the tube. I'm not able to visualize anything. Give the bougie. Okay. Give some pressure. Okay. Okay. Thread the tube in and secure the airway. Auscultate.
Auscultate. Okay. Checking for R entry bilaterally. Yes. R entry in an equal check. Yes. So let's give it to sir.
Yeah.
Let's connect the warmers.
Yes.
Maintain the temperature, core body temperature 35.
End tidal is there. Fine.
Anesthetist, are you ready? Can I proceed?
Yes, sir.
Sisters, yes, please come. Let's give me the drip. Make it fast. I should open the abdomen in less than a minute. Come on, make it fast.
Ma'am, BP is getting low, ma'am. Shall we connect NORAD, ma'am?
Get the NORAD ready. Rush the warm fluids. Crystallize. Report. Get the report.
Get the NORAD ready.
NORAD.
NORAD ready, ma'am. Connected. Yes, ma'am.
Patient.
Central line is on. We can connect it here.
Yeah.
Vasopressin also.
Okay, can I paint? Drips, please.
Step. Patient
Okay,
blood group and the AB positive. Ma'am, report is ready, ma'am.
Okay, drips are ready. Yeah, knife, please.
Ma'am, blood group is AB
Can I
positive,
start?
ma'am. PD is 18, ma'am. INR 2, ma'am. ABD 45, ma'am. Okay, ma'am. 5.
Yeah, can I start? Yeah. Can I have the right tube in place? I need the stomach decompressed.
Yes, sir. Yes, sir. Right.
Fast.
Yes, sir.
Yes,
Yes, sir. We are insert.
Yeah, suck the stomach, suck the stomach. Yes. Yeah. Yeah, there's a lot of blood here. Give me a mop, please.
Brother,
Suction, please.
blood ready and பார்த்துக்கலாங்க.
Suction, please. Yeah, please suck, please suck.
Okay, sir.
Please suck. Yeah, yes, keep sucking. Please.
Yes,
Give me a mop. Give me a mop. Yeah. Okay, I put a pressure on the splenic vein. The liver looks okay. There is no any other injury. Only the splenic lacerated. Kidney looks all right. There's no problem with the kidney. I think somebody has already catheterized in the ear, so urine is clear.
Yeah.
So we don't worry about that.
urine
Okay.
output.
Give me a clamp. Give me a clamp. Yeah. Apply the. Okay. Right.
Surgeon is going to clamp.
Yeah.
Get ready.
Another clamp, please. Another clamp, please. Okay. Right. Now I have got the control. Don't have to worry, anesthetist.
Yes.
You can go ahead. Okay. Right.
BP, heart rate, and saturation.
Yeah. Give me one more clamp. One more clamp. Yes.
Circulate
one more
it.
clamp on
Get the
proximal side.
products ready.
Yeah. Give me
So
a
anytime we
long
may require
scissor.
transfusion.
Yeah, and keep sucking as I'm cutting blood. Yeah. Okay, right. Now it's well under control.
Let's get an
How,
ABG
how,
done.
how's the pulse? How's the pulse?
Yes, sir. Patient is tachycardic.
BP?
Sample send, ma'am.
BP is 90-50.
Yeah, you can pump in some blood, please. Yeah, okay. We'll just remove the spleen. Give me scissors, please. Yeah. Cautery? Yeah, right. Yeah, the spleen is out.
Given some calcium also.
Spleen is out.
Transfused to
Spleen is out.
2 PRBC.
So give me it. Let's tie it up. Give me a tie. Tie, please. Free tie.
So 2 PRBCs
Yeah.
are transfused, then FFP is on floor,
Yeah.
so you can go ahead.
And yeah, I tied the splenic vessels.
Yes.
So bleeding well under control. Let me have a look at the other organs again.
Yeah.
The spleen looks fine. Stomach is already intestine, so there's no perforation. Bladder is okay.
Okay.
Kidneys also look fine. Yeah, come on, just give a good wash to the abdomen.
Okay.
Get me a
The
good
patient hemodynamics
yeah.
holding.
Full suction,
so you can
please.
go ahead.
Yeah.
Yes, sir.
I think we'll put a drainage tube. Give me a small
Yes.
drain, please.
Yeah.
Yeah.
So,
Yeah, drain.
Drainage.
And later,
Yeah.
after surgery, probably you need to advise these guys to give a vaccination, pneumococcal vaccination.
Yes, sir.
Yeah. Right.
Yeah. Stabilize.
Yeah. Closure.
Yeah, improving.
Yeah. Closure.
And
ready.
BP is also 90-60. It's
How is
building
it?
up.
How's the urine output, please?
It's point.
No blood.
It's adequate, sir.
No blood. No blood.
No.
Okay, right. Okay, shall we put sutures or? I think I'm too tired. Let's put staples.
Yes, sir.
Use staples.
Hemostasis is secure.
I put staples. Come on, give me staples. Okay, right. Okay.
I
Put
can't
a dynaplast and be done with it.
MTP protocol
And
stop பண்ணிடுங்க.
ship the
Doctor
patient
complete
ICU.
பண்ணுங்க.
Are you going to keep on the ventilator or off the ventilator?
Counts coming still. Okay.
Okay,
Sir,
right.
counts correct, sir. Sir, counts correct, sir.
Yeah, thank you.
Had a blood transfusion and there was a baseline metabolic acidosis. We have planned for a post-op ventilation and ICU stay, sir. So we are not going to expect.
Stay MS wood in this, sir.
Yeah, anything else? All good? Yeah. Thank you very much, sisters. Thank you so much, sisters.
ஓகே சிஸ்டர் சிஸ்டர் என்ன ரெடி பண்ணோம் என்ன இருக்கும்
So I am Dr. Sendil, consultant on-call anesthetist here. So we have had an emergency laparotomy with a splenic laceration.
Okay, sir.
So the patient pre-op had a metabolic acidosis. There was hemodynamical instability also to start with. We have transfused blood. So we have not reversed the patient. Planned for post-op mechanical ventilation and an ICU stay. Since his baseline HP was 5 and just the investigations report came and sugars were also high, probably we'll ventilate him and overnight and you can take a call on how he goes.
So is the patient on any inotropic support?
Yeah, we have just started on baseline NORAD. Probably when you receive it, you may taper down.
Okay, sir. We'll take care of it.
Thank you.
Sisters, please see if the attenders have come. We need to talk to them. We have done the surgery without their... Yeah, please do that. Thank you very much. வணக்கங்க, நான் டாக்டர் மோகன் ராவ். உங்கள் பேஷண்ட் குமார். நான் தான் ஆப்ரேஷன் பண்ண எமர்ஜென்சி. நீங்கள் இல்லாத டைம்
பேஷண்ட் எப்படி இருக்காங்க சார்
இப்போ பரவாயில்ல, நல்லா கண்ட்ரோல் ஆயிடுச்சு. ப்ளீடிங்
என்ன சார் ஆச்சு உங்களுக்கு
ஆக்சிடென்ட்டில் ஸ்ப்ளீன் இன்ஜுரி ஆகிட்டு நிறைய பிளட் லாஸ் ஆயிடுச்சு. ஸோ ஆப்ரேஷன் பண்ணிட்டேன்.
நல்லா இருக்காங்களா
நல்லா இருக்காங்க. 2 நாள் ஐசியூவில் தான் இருப்பாங்க. வெண்டிலேட்டரில் இருக்காங்க. ஒன்றும் பயப்படாதீங்க. ஓகேங்களா?
எப்படியாச்சும் காப்பாற்றி கொடுத்துருங்க சார்.
ஓகே.
Yes, sir. So we'll go by as per plan. Given a detailed handover of post-operative ICU requirements also. So we'll take post-operative investigations, coordinate with the multidisciplinary team, ICU team. Then we'll see how it goes. Okay. Thank you, sir. Thanks for everything. Thank you, sir. Thank you, team. Thank you, everyone, one and all, for such a elaborative case scenario. This thing and the patient who outsmarted even the real patient with complete dedication.
Like I said before, this time's theme is anesthesiology in health emergency. So hemorrhage is a typical emergency in which anesthetists get involved, and we are involved from the time the patient enters the hospital to the because we've run out of time, we stopped the scenario. Otherwise, we would have continued into the ICU as well. See, other thing very important as far as anesthesia and this theme is team play. That is interdisciplinary cooperation and flattening of hierarchy. If you notice, there were so many people involved. So just because the ER patient is shifted from the ER to the OT, the ER nurse did not give up the responsibility. The ER nurse, Adi, come forward. He followed it up with the investigations. He made sure that the investigation reports reached the theater. He made sure to coordinate with the blood bank even after handing over the. So we need support like that. Similarly, the blood bank responded immediately by giving us uncross match O negative and did not ask for IP number and all that, right? So even an unknown patient a name, unknown group, we can transfuse O negative immediately. So that is how the blood bank will respond. So never hesitate to ask the blood bank for O negative blood if it's a genuine emergency. Don't think that the blood group report has to come before you ask. The other thing, if you noticed, is everyone stood up and took responsibility. So there is no hierarchy. When there is an emergency, there is no hierarchy, no senior, no junior. Though Dr. Mohan Rao is saying, no, I want to operate, the circulating nurse insisted that there should be a timeout. Similarly, in the end, she insisted that we should do a count. Even if the doctor forgot to ask for a cross matching of blood, the nurse steps up and says, shall we send the blood for? That is what we expect from all of you. When you are in a team, and you're working towards the safety of the patient, there is no seniority. In anxiety, I might forget something. You will remember, you should remind me. If I'm struggling to intubate, you should be the one who should call for help, even if I forget to call for help. So those are the things we wanted to highlight in this thing. So any concluding remarks, Sendil? So please give a big hand. In 24 hours, they have yesterday on WhatsApp and today from morning 8 to 10:30 before the first patient was wheeled in. That's all the time they had to practice, because you know how culturals were going on last week. Then there was Diwali holiday, different mood and all. So we didn't want a break in Karkandi, so they rose up to the occasion, and so give them a big hand.
Thank you one and all for such a gathering and just supporting us for this event. And that is what, as ma'am discussed, ma'am was the main motivating factor. Ma'am wanted to give a case scenario, different. Yes, sir. That was the motivating factor by online tracing, sir. So that's what it's. So that was there. And yes, sir. Special note of thanks to our team and Mohan sir. We suddenly got a surgeon. Of course, sir is there. We suddenly got a surgeon. Just came for a walk-in, and we suddenly grabbed him. And with absolutely any hesitation, he was fine. Maybe a real-time patient. That is what. Thank you, sir. Thank you. And.
Half the way he said, I have a splenectomy, I have to go. I didn't realize it was Karkad. Only after seeing it, I realized the splenectomy is now here. That's just the dedication motivation. 9:36 is the first time he knew that he's on today.
He's on today.
Yeah, I just want to, I think Dr. Vidya and sir has told everything, but I do not know how many of you understood the difference when we have asked for the surgery pack 2 and we have done the surgery without the reports. We are not going to wait for it because it is a life-threatening emergency. We have a splenic injury, we can't wait. Only thing we'll want is blood grouping. Even that we are doing without cross-matching. And everything from the time we decide to operate and we operate should not be more than 8 to 10 minutes. It should be very fast because we have to control the bleeding. That was not actually, I do not know how many of you all understood that. It is not elective surgery where we wait for everything. That's why I told the blood bank to get the blood as soon as possible and not, normally blood bank will take 10, 15, 20 minutes. That's not the case here. We want it immediately. So that's the difference between elective surgery and emergency. Once you get in and control, then you have all the time in the world. You can do whatever you want. So one more thing I like to tell is, particularly to the young nurses here, there's, if I can take little, yeah. So there's a difference between laparoscopic surgery and open surgery. In open surgery, in emergency, we cannot take more than a minute or two to open the abdomen. We can't do layer by layer and open. We just go straight away in one single layer, open the abdomen, control the bleeding. Unlike in elective procedures with skin, fascia, or 3 layers of muscle, that's not going to happen here. So young surgeons may not be trained to do open surgeries. They were very well trained in laparoscopic surgeries. So I don't know how many of you will be working in hospitals where there are young surgeons who are not trained in open surgeries. I just wanted to tell this to you all. Thank you, Dr. Pata.
Very nicely done show, I should say. The patient goes to the ward and Dr. Mohan Rao will see a couple of days, and the patient comes back to Mohan Rao for suture removal, and the patient's wife only knows him. They don't know all the unsung heroes who worked very hard to make the patient live, and actually, I mean, this happens day after day, year after year, and that sacrifice is something which is worth appreciating. I think they're all the truth, as the poster says, they're the people behind the scenes, and they do all the hard work.
Thank you, sir. Thanks,
Thank you for that.
That's a very sad part where ultimately the patients think it is the surgeon who did everything, which is not true. The surgeon's role is the smallest part. It's all pre-operative and mostly post-operative and ICU care. But patients, attenders will come and tell, thank you, sir, you saved my life, my husband's life, and all those things. But definitely, as Dr. Pata said, the rest of the team are the one who actually made the patient is alive.
Thank you, sir. Thank you, sir.
Good afternoon, all, and happy Diwali. All of you are back, and still happy to see the auditorium full. So it's good to see all of you. And on World Anesthesia Day, Sir Dr. Pata sir and Dr. Vidya ma'am have arranged this special program, which was a true it's a true treat to see. And many of you wouldn't have gone into OT. So I think it's really good to see this on screen actually. And if you see, these are the anesthetist and the team, OT team, they're all called the unsung heroes. So they are the heroes, behind the scene actually. So congratulations to Pata sir and Dr. Vidya ma'am to bring this out and show it to everybody. And actually, Mohan Rao sir, he even cancelled his garlic bread to come to the. He didn't have time to eat, and he said splenectomy. So we thought it was in the theatre. So actually, he cancelled it to come to the program, sir, because we all know it starts at 1. Okay, so congratulations again. And 25th, this which episode, sir? Karkanda? 33, and Marvelous is 250. 250. Okay. So hearty congratulations to sir and Dr. Vidya ma'am, and for their contribution to the academics. Thank you, sir. Thank you.
Thank you, ma'am. Thank you, OT team and all the anesthetists. Now let's move on to the quiz. So if you know the answer, please raise your hands. If there are multiple answers without raising your hands, the questions will be disqualified. So the first question, the primary energy source for the brain under normal condition is? I want the junior staffs to answer. Yes, tell sister. Correct. Glucose. I would request MS ma'am to give over the prize. Introduce yourself, sister.
Mocharakini CTIC.
Next question. Which cranial nerve is responsible for sensation in the face and motor function for chewing? The question will be disqualified. No, it's wrong. Any other guess?
Trigeminal nerve.
Yes, it's the right answer. Introduce yourself, sister.
I am Shanmuga Priya from 6A.
Next question. Which vitamin is essential for the synthesis of clotting factor in the liver? No, only one has to answer. No prizes for this question. Please raise your hands if you know the answer. Which organ can regenerate itself completely? Nidisha sister? Yes, correct. What is the correct angle for intramuscular injection in adults? Please raise your hands.
90 degree.
Yes, correct.
Lavanya from MDCC.
Please get your prize. The main purpose of preoperative fasting is reduce nausea, reduce anxiety, prevent aspiration during induction, improve anesthetic onset. Please raise your hand.
Preventing aspiration during induction.
Yes, correct. Which organ in the human body has no pain receptors? Yes, sister. Yes, correct. Brain has no pain receptors. Before meals is represented by which Latin abbreviation? QID, PC, AC, HS. Can you explain that? Sorry.
AC anticibos, அதாவது before food.
Anticibum. She'll get the prize. So AC is anticibum before meals, PC is postsibum after meals, QID is quarter in D, HS is ora somni at bedtime. Which vitamin deficiency causes bitot spots in eyes? Yes, sister. Yes. So, bitot spot is a foamy, whitish triangular patch that appears on the conjunctiva, and it is due to vitamin A deficiency. Last question: which microorganism is known for producing antibiotics naturally? Streptomyces, Escherichia, Staphylococcus, Candida. Please raise your hand if you know the answer. Yes, brother.
Streptomyces.
Please collect your prize, sister. Sister, your name?
I am Priya, CTIC.
Thank you, everyone. That's all for today.